Hi, my name is Jake DeClean. I'm a fourth-year pharmacy student from Concordia University. I'm going to talk to you today a little about cerebrovascular disease, or most notably known as stroke. So under the umbrella term of cerebrovascular disease falls two distinct categories that we'll talk about today. One being ischemic stroke and the other being hemorrhagic stroke. So an ischemic stroke is an obstruction within a blood vessel supplying blood to the brain. You may have a less severe ischemic stroke symptoms called a transient ischemic attack, or TIA. So this is often labeled as a mini stroke where the blockage is only for a short period of time. You may see symptoms initially that may point you in the direction towards an ischemic stroke. However, these symptoms they resolve on their own. A hemorrhagic stroke can be defined as either an intracerebral hemorrhage or subarachnoid hemorrhage. Intracerebral hemorrhage being rapidly developing clinical signs of neurological dysfunction attributable to a focal collection of blood within the brain or ventricular system that is not caused by a trauma. Whereas a subarachnoid hemorrhage is neurological dysfunction and or headache due to bleeding in the subarachnoid space. When we get to hemorrhagic stroke, we'll talk about a little bit of the pathophysiology and where these bleeds may occur. But these are really the two main causes of cerebrovascular disease that we'll talk about today. For today, we will start with ischemic stroke. Next, let's talk about the pathophysiology of ischemic stroke. Thrombus, embolus, or hypoperfusion can cause anoxia to brain tissue. So a thrombus is something that it just occurs within the artery. It can occur within the smaller arteries of the brain. An embolus is something that may occur in the heart or may occur in the lungs, break off, and then go into these smaller vessels of the brain and get lodged in there. Hypoperfusion can be caused by carotid stenosis. Patients at risk for carotid stenosis are those with hyperlipidemia, who smoke, any risk that really is attributed to like heart disease that you may think of. So as I mentioned in the previous slide, anoxia can lead to all these issues mentioned here. You can get membrane depolarization, a release of intracellular potassium. This can lead to seizures. You can get an increase in lactic acidosis, glucose metabolism, deplete those energy stores, inhibit protein synthesis, which can all lead to cell death. So here's a nice little, flow graph from the guidelines. So this looks at symptom onset as well as imaging to see if you can rule in or rule out a transient ischemic attack, a silent CNS infarction, or an ischemic stroke. So if a patient were to present with symptoms of less than 24 hours, it's possible that it could be just a transient ischemic attack. It could still definitely be an ischemic stroke as well. The pathological imaging, so a CT or MRI, is the best way to really rule in ischemic stroke compared to a transient ischemic attack. So our approach to treatment is pretty simple. Our best strategy is primary prevention and never allowing an ischemic attack to propagate. If one does occur, however, time is tissue in this population. You want to rapidly recognize symptoms by the FAST acronym, which I'll talk about in the next slide. Supportive care is important, the ABCs being airway, breathing, and circulation. This is something as a student you can monitor. You can watch blood pressure, heart rate, watch those O2 sats to see if the patient is staying hemodynamically stable. Next, you want to determine the etiology of the stroke, whether it's ischemic or hemorrhagic, which is the reason that patients are sent to the CT scanner relatively quickly. If we do see that a stroke has occurred, we want to reduce that secondary brain damage as quickly as possible and with ideal therapies. If all this occurs, patients want to get admitted to early rehabilitation, and then we use secondary prevention to hopefully avoid these situations from occurring again. So for primary prevention, it's important to maintain our blood pressure goals given to us by JNC8. Increasing pressure, especially in the smaller vessels of the brain, are more likely to clot or hemorrhage. So those goals set to us by JNC8 being less than 140/90 for blood pressure, except for a few special populations which are less than 130/80. In patients with AFib, they're more prone to clot in their atrias due to the blood pooling. That's not an issue with stroke, obviously. However, these thrombi may break off and embolize into the smaller arteries of the brain. So it's important to keep our INR within therapeutic ranges. In our patients with dyslipidemia, to prevent stenosis, as I talked about in the pathophysiology, statin therapy is important for this. As well as with all diseases, dietary and lifestyle modifications are important. Removing cigarettes from daily routine is also very important. So it's important for us to rapidly recognize the symptoms of a stroke. We've seen the commercials before with the FAST or FAST acronym that they use. This being facial droop, arm numbness or weakness, slurred speech, and then time to call 911. So the clinical presentation you may see in the ED is aphasia, agraphia, apraxia of the limbs, hemiparesis, hemisensory, or loss of visual field deficit. So the NIHSS, or National Institutes of Health Stroke Scale, scores patients from 0 to 42, with 0 being normal and 42 being pretty much in a coma. We'll see on the next slide how a neurologist goes through determining the score for a patient, so I'll talk about that on the next slide. The diagnostic tests that we use are a CT scan to determine if there's any hemorrhagic stroke going on. An MRI is more, you can see with high resolution, the ischemic areas if a patient were to present with an ischemic stroke. CT angiography is another way that you can locate the vascular lesion, where in the brain that the stroke has occurred. And an EKG is important to determine if a patient is in atrial fibrillation, if they may have embolized and thrown a clot into their brain. So here's that NIHSS tool that neurologists will use to determine the severity of a patient's stroke. They'll go through the level of consciousness, response to questions, they'll do pupillary response with light, visual fields, if they have facial palsy, their language. They'll look at the motor symptoms of their arms and legs. You'll see them hold both in the air for 5 to 10 seconds. If they're unable to do this, they get a worse score. At the bottom, you may see that a less than 4 shows a good prognosis, and we don't need to administer TPA. However, at Freighter, we still may administer TPA given the risks outweigh, or the benefits outweighing the risks. So for acute treatment, our main goal is to reduce neurological damage. The first thing we want to do is give the patient supportive care, airway support if they need it, and they should be satting at 94% for oxygen. Patients eligible for TPA should have their blood pressure lowered to less than 185 over 110, as TPA can cause hemorrhages. They should also maintain that blood pressure for less than 180 over 105 for 24 hours after initiation of TPA. The last two, the antipyretic medications and the treatment of hypo and hyperglycemia, you may see more on the floors rather than in the ED. We'll talk a little bit more about hypoglycemia and doing finger sticks to get a blood glucose reading when the patient is first seen in the emergency room. For our hypertension treatment, our main two medications that we use are Labetolol and Nicardipine. If a patient has a blood pressure of greater than 185 over to 110, if we want to administer TPA, we want to get them lower than that number. So Labetolol is administered 10 to 20 milligrams over 1 to 2 minutes, and you may repeat that times 1. Other agents we may use for treatment of blood pressure is hydralazine or enalapril. However, and if all of these are refractory, we may end up going to sodium nitroprusside. I'll talk about doses with each in the next slides. We'll start with Labetolol here, even though Labetolol and Nicardipine are both interchangeable for the first-line agents. The dose we're going to give is 10 to 20 milligrams. You may double that every 10 to 20 minutes to a maximum of 300 milligrams. You may also start an infusion of 2 to 8 milligrams per minute. The mechanism of action, so it's a non-specific beta blocker with alpha-1 antagonism. Just something important to note, there's a difference between the alpha and beta blockade between the IV and oral formulation. So the alpha to beta blockade in IV is 1 alpha for every 7 beta blockade, whereas in the oral formulation it's 1 alpha for every 3 beta blockade. Just something important to note, you'll probably never see oral given down in the ED in these stroke patients. So the peak effect is seen within 5 minutes of initial dose, and it has a relatively long half-life, so you can see accumulation with Labetolol. Nicardipine is the blood pressure medication I have most seen in these patients with ischemic stroke. For the dose, you want to start an infusion at 5 milligrams an hour and titrate up 2.5 milligrams an hour until that blood pressure goal is reached. The maximum is 15 milligrams an hour. Once you hit that blood pressure goal, you want to decrease the rate by 3 milligrams an hour, and that's due to these complicated pharmacokinetics. It has both alpha and beta. So you initially see that alpha effect, that's the quicker one. Then once that blood pressure goal is hit, the beta comes into play, which is why you want to decrease that rate. The mechanism of action for nicardipine being a calcium channel blocker. I talked about Nitroprusside as one of our second or third line therapies to use if we're unable to use nicardipine or Labetolol for whatever reason. So the dose for this is an infusion starting at 0.5 mics per kilogram per minute. You need continuous arterial blood pressure monitoring with this one since it's such a potent, it has very quick onset of action. It's a direct venous and arterial vasodilator by increasing the nitric oxide in the venous and arterial system. You may also get a risk of cyanide toxicity with this medication. However, you really only see this with prolonged duration, relatively higher doses, or if the patient's in renal failure. So the rule of threes is something to think about with this medication. So that would be the high dose of 3 mics per kilogram per minute for a prolonged duration of 3 days with a serum creatinine of greater than or equal to 3 milligrams per deciliter. So that'd be that renal failure component. So next we'll go into pharmacological therapy. Only 2 therapies are given class 1 recommendations for the treatment of acute ischemic stroke. One being Thrombolytic Therapy or Tissue Plasminogen Activator, or Alteplase if you know it by the brand name, or Antiplatelet Therapy, that being Aspirin. So this slide shows a little bit of the mechanism of action of TPA. On the left side you'll see the ending portion of the clotting cascade with fibrinogen being activated to fibrin by thrombin. You get an aggregation of platelets and thrombus formation. The right side is you see plasminogen being activated to plasmin by TPA, and then you get a degradation of that thrombus and you get fibrin products that may form. So the plasmin is the activated enzyme which ends up degrading that process, and it can only be activated by TPA. The first medication we'll talk about is Tissue Plasminogen Activator or Alteplase. The dose we give for this is 0.9 milligrams per kilogram with a max dose of 90 milligrams. Per the guidelines, the time that the patient arrives to the ED till the time that the drug should be administered should be under 60 minutes. Freighted has a goal of less than 45 minutes. That's just specific to their site. And this should be administered within 3 hours to 4.5 hours. I'll talk a little bit about the trials that looked at this window that we can administer TPA being 3 hours to 4.5 hours in later slides. The first 10% of the dose should be given as an IV bolus, and the remaining 90% should be over an hour. So it's kind of unique how it's supplied. In this box, you'll see sterile water, you'll see the TPA, and then you'll see a spike. So the first thing, you want to keep everything under sterile, practices as best as you can. You're going to want to spike the sterile water first, and then on top of that, you can put the TPA. Then you're going to want to invert that and allow the water to drain into the TPA vial. And once that's complete, you're going to want to slowly swirl the TPA until it is all dissolved. You're not necessarily going to want to use a syringe and needle since there's going to be a large hole from the spike, so you just may want to use another spike to draw up the medication. So this slide is looking at some of the exclusion criteria of patients that cannot be administered TPA or shouldn't be administered TPA. Some lab values that we may look at as pharmacists, that elevated blood pressure I kind of talked about, we want to treat to less than 185 over 110. Platelet count of less than 100K, patients shouldn't be given TPA. If they received heparin within 48 hours and have an abnormally elevated PTT, if they currently use anticoagulants with an INR of greater than 1.7, any patient that uses direct thrombin inhibitors or direct factor Xa inhibitors should not receive TPA, or if they have that blood glucose of less than 50 milligrams per deciliter, they may be in a hypoglycemic state rather than a stroke state. So it's important to get that finger stick glucose immediately right away. So if you want to give TPA within 4.5 hours of symptom onset, there's some additional exclusion criteria. That's just how it was studied, which I'll talk about in the next few slides. And that's patients older than 80 years old taking oral anticoagulants regardless of the INR, that elevated baseline NIHSS score, or a history of both stroke and diabetes. The first trial I'll talk about is the NINDS Trial. This was really the first landmark trial to get TPA approved for ischemic stroke patients. This included 624 patients presenting within 3 hours of those ischemic stroke symptoms. There was a long list of exclusion criteria, and many were related to the risk of bleeding, since TPA can increase that risk of bleeding as well. There was no exclusion on the basis of severity of NIHSS score or any age exclusions at all. The primary outcome was NIHSS improvement at 24 hours and global assessment of 4 clinical outcome scales at 3 months. There was no difference in NIHSS scores at 24 hours, but TPA administered did show favorable outcomes at 3 months. Symptomatic intracranial hemorrhage occurred more frequently with TPA compared with placebo. We would probably expect that since TPA can increase that bleeding risk. Minor bleeding was also more common. However, there was no difference in mortality when comparing these bleeding risks. So the next trial that we'll look at is the ECASS III trial, and that looked at just extending that duration of symptom onset when we can administer TPA from 3 to 4.5 hours. This trial excluded those patients that came in with severe stroke scores of greater than 25 per the NIHSS. The primary outcome was disability at 3 months. Patients were randomized to Alteplase those patients randomized to Alteplase had complete or near complete neurologic recovery. Again, there was a 10-fold increase in intracerebral hemorrhage. However, no difference in mortality between Alteplase. Aspirin therapy is our only other therapy that you can use with a Class 1 recommendation per the guidelines. It should be administered 24 to 48 hours after stroke onset if TPA is given. If TPA is not given, you can administer within 24 to 48 hours within those stroke symptoms. For secondary prevention, you have your choice between aspirin, clopidogrel, or aspirin and dipyridamole, also known brand name Agrinox. Aspirin can be anywhere between 50 to 325 milligrams for secondary prophylaxis. However, studies have shown that 325 milligrams is no more effective than 81 milligrams. The Capri trial showed that clopidogrel was slightly more effective than aspirin use in reducing strokes. The combination of clopidogrel and aspirin is still under a little bit of investigation. The CHANCE trial showed that the combination was superior to aspirin alone in those minor stroke patients. And the POINTS trial is still under investigation, looking at the combination of clopidogrel and aspirin. For anticoagulation therapy, we don't necessarily use it strictly for secondary prevention, only if there's a cardioembolic risk with the patient. So an example of this would be a patient in AFib. The guidelines also recommend lowering of blood pressure regardless of what the patient's baseline blood pressure is. So that goal reduction of about 10 millimeters of mercury over 5 is what they recommend, and also statin therapy for these patients. All right, we're on to hemorrhagic stroke now. This is less intensive than ischemic stroke. We just have less treatment options, and we're really doing more supportive care than anything. Pathophysiology of hemorrhagic stroke is presence of blood in the brain causing damage to brain tissue through mass effect, and blood is a direct neurotoxic to brain tissue. Compression and increased intracranial pressure can cause the potential for herniation. So you see on the picture there to the right, these are some of the areas that it can occur. It can occur intraventricular, it can be intracerebral, subarachnoid, subdural. A patient presenting with a hemorrhagic stroke may be similar to ischemic stroke, which is why it's important we get them to the CT scanner as quickly as possible. A headache is more common in these hemorrhagic stroke patients than ischemic. A subarachnoid hemorrhage patient may tell you it's the worst headache they've ever had, Other symptoms may be vomiting, they may be in a coma, decreased loss of consciousness, they may be seizing, etc. The elevated blood pressure comes from the equation cerebral perfusion pressure equals mean arterial pressure minus intracranial pressure. So in order to continue to perfuse the brain, since we lost all this blood, we must increase our mean arterial pressure. So that's why you may see patients with these pretty high blood pressures that come into the ED. So treatment for these patients who come in with hemorrhagic stroke, very similar to ischemic stroke. You want to start with your supportive care. Make sure the patient has an airway, they're breathing, and they're circulating blood. Really the main area that we as pharmacists or pharmacy students can help out the neurologist or the treatment team is if patients are anticoagulated, how can we reverse these coagulation deficiencies in order to stop the bleed? So I won't get into what agent we should be using if a patient's on warfarin versus dabigatran, but here are some of the agents you may see in the ED: vitamin K, FFP, PCC, factor VII, or platelets. Blood pressure treatment for these patients is very important. This will help prevent rebleeding, which is an elevated risk within the first 12 hours. Some medications are similar as ischemic stroke, being Labetolol, Nicardipine, or Nitroprusside. You may also see antifibrinolytic therapy in these patients. Those are aminocaproic acid or tranexamic acid. So the guidelines really recommend treating to a cerebral perfusion pressure of, I believe it's 50 to 70. However, we don't monitor that in the ED. So for Froedtert, an achievable goal blood pressure of less than 160/90 is ideal for these patients who come in with hemorrhagic strokes. This slide's just looking at aneurysmal treatment. These aneurysms can eventually propagate into hemorrhagic strokes. Really the only treatment for these aneurysms are surgical techniques like clipping or coiling. You may also see that we are treating for elevated intracranial pressures in the ED. The two therapies that we may use for these are hypertonic saline and mannitol. This is more just to round out the treatments we may see in stroke patients. So you're not necessarily going to see this in the ED, but once they transfer to the floor, they may be started on any one of these therapies. For vasospasm treatment, you may start nimodipine, which is a lipid-soluble calcium channel blocker. Studies didn't show any decrease in vasospasm rate, but they improved neurological outcomes overall. While the guidelines or the literature doesn't recommend starting statin therapy, we at Froedtert do still implement statin therapy. So let's round out this talk a little bit with a case and how you'd walk through a patient presenting to the ED. So MM is an active woman, 63 years of age, who lost consciousness and collapsed at home. Her daughter, who was visiting at the time, did not witness the collapse, but found her mother on the floor, awake, confused, and slurring her speech. The daughter estimated that she called EMS within 5 minutes after the collapse, and the EMS responded within 10 minutes. They notified Froedtert that patient had positive stroke symptoms and would be arriving to the trauma bay within about 15 minutes. The patient's daughter accompanied her mother. So now that we've went through the discussion between ischemic stroke and hemorrhagic stroke, what should you be thinking about as a student when this patient arrives to the ED? So you're going to want to work efficiently, quickly when the patient comes in. So what's going to happen is the neurologist will conduct an initial assessment, then the patient will be taken directly to CT. So it's very important to gather information in a timely manner. You remember that door to needle time that we want to administer TPA is 45 minutes per Froedtert standards. So you really don't have a ton of time to really gather patient information. It's going to be important to shape your workflow efficiently. So after a patient's arrival to the trauma bay, in the case situation, it's nice that the patient's daughter is there that can maybe help you with medication history. However, that's not always the case, and the patient's going to be going through this neurological exam and then taken directly to CT. So you may have to look through Epic, you may have to find their pharmacy to get any medication history that you can. Really, the most important thing we're looking for is those anticoagulants. Next, you're going to want to determine a patient's weight, and that's going to be used to calculate a TPA dose. You're then going to want to evaluate pertinent labs. If you want to remember back to the exclusion criteria for TPA, that's with that low glucose less than 50, platelets less than 100K. that INR elevated of 1.7 are really the ones that come to mind when you want to evaluate pertinent labs, and you may want to remind providers to order these labs so we can get them back in a timely manner. Once all of that comes together and the patient's a good candidate for TPA, you're going to want to grab the stroke box and then wait until you get the okay to prepare TPA, since it's a expensive medication. That's really all I have for today. Thanks for listening. Here are some references. Any questions, let your preceptors know. Thank you.